Hi, everyone, and welcome to the Foundation for Sarcoidosis Research webinar, Cardiac Sarcoidosis and the PAPLAND Study. I'm Kate Anastasia, Director of Global Patient Programs, and I'll be your moderator for today. Before we get started, though, I'd like to go over some housekeeping. So this is a webinar, so we will not be able to see or hear audience members. So this means you can use the raise your hand function. If you do use your raise your hand function, we're not going to be able to respond directly. We do encourage you to submit your questions directly into the Q&A at the bottom of the screen. If you have any technical difficulties, please chat me or Kristen Vargas directly, and we'll do our best to help you out. And this session is being recorded, so the link will be shared in a follow-up email to everyone who registered for this webinar. It will also be available in FSR's video library later this month. Next slide, please. The information presented in today's program is intended for educational purposes only. It should not be considered medical advice. We always encourage individuals to speak with their own healthcare providers about any questions or decisions that are related to their care. Next slide, please. And I just want to take a moment to thank our generous sponsor, Canova, formerly Mallinckrodt Pharmaceuticals. Next slide, please. Today's webinar is also going to highlight the importance of research in sarcoidosis. And I just wanted to take a moment to share important information about the FSR SARC Patient Registry. It's a secure, IRB-approved, HIPAA-compliant online database where people living with sarcoidosis and caregivers can share their health information and experiences to help advance research and improve care. So you too can be part of this patient-powered global resource with over 7,000 participants from about 70 countries contributing real-world data on sarcoidosis. The FSR SARC Patient Registry is now open on a new, more user-friendly platform, and you can learn more about the patient registry by visiting our website. And now I would like to introduce FSR's President and CEO, Mary McGowan.
Thank you, Kate, and hello, everybody. Thank you so much for joining us today. I want to kick us off with a very happy Heart Month. As you may know, February is National Heart Month, so this webinar is very timely as we take the time to learn more about cardiac sarcoidosis and to hear from our experts today on the latest on cardiac sarcoidosis, and we appreciate you joining us. So on behalf of the FSR, it is my pleasure to welcome you to today's webinar. While estimates vary, studies suggest that cardiac involvement may occur in up to 25% of the people living with sarcoidosis, and often without obvious symptoms. And because cardiac sarcoidosis can lead to serious complications, early and routine screening is critically important, and ongoing research, including clinical studies, is essential to improve detection and treatment. So today's webinar will touch on these concerns and a lot more. Please know that the FSR team is here to support you, to connect you with others in the community, and to help you learn more about living with sarcoidosis. We also work to bring opportunities to you to become engaged in our efforts and to help raise awareness about sarcoidosis and to advocate and advance sarcoidosis research. With that, it is now my honor and pleasure to introduce today's speakers. Dr. Jordana Kron graduated magna cum laude from Princeton University with a major in chemistry and went to medical school at Johns Hopkins Hospital in Baltimore, where she also completed internal medicine residency. She completed fellowships in cardiology and cardiac electrophysiology at the University of Florida. She joined faculty as a clinical cardiac electrophysiologist at Virginia Commonwealth University in 2008, where she was program director for the Electrophysiology Fellowship Program from 2013 to 2017, and an associate professor since 2015, and professor since 2021. She is a founding member of the VCU Sarcoidosis Clinic. Her primary research interest is cardiac sarcoidosis. She served on the writing committee for the HRS expert consensus statement on the management of arrhythmias associated with cardiac sarcoidosis and was section leader for management of atrial arrhythmias and conduction system disease in patients with cardiac sarcoidosis. She is a founding member of the Cardiac Sarcoidosis Consortium, an international collaborative research group committed to furthering the understanding of cardiac sarcoidosis. In 2018, she was selected as VCU Center for Clinical and Translational Research Translational Scholar to support her research on prevention of arrhythmias and heart failure therapy in cardiac sarcoidosis. She has received funding from the VCU Johnson Center, the VCU CCTR, and the Pauli Heart Center to support her translational research. She received an AHA Collaborative Sciences Award to investigate novel therapy with interleukin-1 blockade and new imaging techniques for cardiac sarcoidosis, and in 2020, an NIH NCATS R21 grant to support a multi-site randomized controlled trial evaluating the safety and efficacy of interleukin-1 to treat cardiac sarcoidosis. And Dr. Dan Culver. He holds a joint appointment in the Department of Inflammation and Immunity. His clinical interests include interstitial lung diseases, sarcoidosis, pulmonary oligoproteinosis, and critical care. Dr. Culver earned his Doctor of Osteopathic Medicine degree at the Ohio University College of Osteopathic Medicine in Athens, Ohio. After medical school, he did an osteopathic rotating internship at Meridia South Point Hospital. He completed his residency in internal medicine and a fellowship in pulmonary at critical care medicine at Cleveland Clinic. Dr. Culver is a fellow of the American College of Chest Physicians and a member of several professional associations, including the American Thoracic Society, the American Osteopathic Association, and the World Association of Sarcoidosis. He is the president of the World Association of Sarcoidosis and Other Granulomatous Disorders. With that, I will turn it over to you, and thank you so much. We're honored to have both of you here today on this very timely and educational webinar.
Let me share my screens. Thank you so much for that wonderful introduction. Get my slides going here. All right, how does that look?
Great.
That's shared. Can you see these slides?
Perfect.
It's great.
Good. Okay, great. Well, thank you so much for having me here today. I'm delighted to be here with FSR and all the patients. I think the patient-facing programs are so important, and it's one of the many things that I love about working with FSR. So what I've been asked to talk about today is what's new in the cardiac sarcoidosis guidelines. So the first guidelines for managing rhythm problems in cardiac sarcoidosis were published in 2014. And I think this was really an important step in this field where we really got together and said, look, let's take a look at what we know, what we don't know, and where we should be going from here. So it really hasn't been such a long time since the first documents were published, but we've come a long way since then. These original guidelines were a joint effort with the World Association of Sarcoidosis and Other Granulomatous Disorders, the American College of Cardiology, the American College of Chest Physicians, and multiple other societies that worked together to produce these guidelines. So what I'll talk about today is first the guidelines, how we write them, who the collaborators are, the timeline, what's new since 2014. So now we're going to rewrite these guidelines and try to incorporate all of the science that has come along in the past more than 10 years. I will discuss some of the critical papers that have been published in the last 10 years that will influence our updated recommendations. And something very important that I wanted to cover today is what does this mean for our patients? What does this mean for you? We're doing all this work behind the scenes, but how does this actually help our patients? So this is really important. This document is putting together a lot of experts in the field to look at all the research that's been done in the past and summarize what we know at this time and what we don't know, which is equally as important, because when we define what we don't know, we can start to talk about what research projects are most important so that we can try to answer those questions that we still don't know the answer to. It can help your medical team make the best decisions based on the current data. And one thing that's very important about this document is that while Dr. Culver and I sit around and talk and think and write about sarcoidosis all the time, because it's not a very common disease, there may be many medical providers that don't have as much experience with sarcoidosis. And so this document really can be used by people who see a lot of sarcoidosis or who don't. And so if you are in a region where maybe they don't have a sarcoidosis specialty center, your physicians can still reference this guideline to have in one place all of the current recommendations for managing this disease. So I think it's very important that this information is compiled and then distributed throughout our medical community. For the revision of this document, these will be the collaborating societies, and within cardiology, the American College of Cardiology, or ACC, and the American Heart Association, the Asian Pacific Heart Rhythm Society, European Heart Rhythm Society, and then WASOG. And so the guidelines will be written by the heart rhythm team, but then they go through additional layers of review so that these other societies make sure they're also approving all of the recommendations and that these recommendations are consistent with recommendations from these other societies. So this is a very big undertaking. When we get approval to write a document on a specific area within cardiology or other areas, it can take more than a year to start to compile that data, come to agreements on the recommendations, and then draft the paper, and then have that paper go through multiple levels of review. So oftentimes it can take about 13 months. In this case, it's actually going to take a little bit longer. And so it starts with the topic nomination, goes through forming the committee, document development, and I'll go through this in a little bit more detail. And then we have to go through external review, and we even have public commentary. And so we're not open for that yet, but coming soon in the future, there will be a link where if you're interested, you can actually see the draft of the document and read through it and submit your public comments. And then finally, at the end, it will be published and presented and shared with the medical community and our patients. So I'm very honored to work with Dr. David Burney, who co-chaired the 2014 writing statement, and who also is co-chair this time. I'll be joining him. And so this is our wonderful committee here. And some of the important things about this committee is that there is international representation, and there's also representation from multiple different specialties. As sarcoidosis patients, you're likely very aware that this disease can affect so many different parts of the body. And so we have pulmonary specialists, imaging specialists to help with our recommendations on MRIs and PET scans. We have a PharmD, a pharmacist on the committee. And very importantly, we have 2 patient representatives, and they are non-voting members of the committee, but they're very important. They make sure that as we are discussing issues, scientific issues, that we are able to keep the patients at the forefront of that and keep in mind, what do these recommendations mean to our patients, and are we making sure that our end result is relevant and prioritizing the patient. So this is a really important part, and this is sort of the meat of the writing process, and it's where we are right now. First, we review all of the data. We look through all of the studies that have been published since our last guidelines. We try to determine how strong those research projects are. So if, for example, a randomized controlled study of a lot of patients comparing 2 different things is stronger scientific evidence than maybe a case series of 3 patients. And so we also consider how strong the data is and how good the science is. We then make recommendations. We have discussions and vote on them. And then we go back to the drawing board, revise our recommendations again, discuss them, and then vote again. And so we have this iterative process where we try to come to agreement on recommendations. We currently have 18 voting members of the committee, and 70% of those, or 13 people, need to agree in order for a recommendation to make it into the document. Members of the committee may not vote if they feel they don't have enough expertise in that particular area, or if they have some kind of a conflict. So the outline of this document is going to be very similar to the one from 2014. And it's going to cover really all of the areas that I think are most important in this field. We start with some introductions and information about the process of convening this document. We go through general concepts and definitions. We then go through diagnosis and screening for sarcoidosis. This can be very important to doctors and caretakers who don't see a lot of sarcoidosis, so we can help guide them. What's the standard process that we should be going through to diagnose our patients and screen them for cardiac involvement? We're then going to hit on all of the major electrical problems that we can see in sarcoidosis. We're going to talk about conduction abnormalities like heart block, atrial arrhythmias such as atrial fibrillation, and then ventricular arrhythmias such as VT or ventricular tachycardia. We talk about defibrillators, who is at risk for life-threatening rhythms that requires a defibrillator, and how we should manage and take care of defibrillators in these patients. Very importantly, the last section will focus on gaps and future needs. As I said before, defining what we know is critical to determining what we don't know and what we still need to learn. And so this future needs section, I think, is really important to sort of have the community agree these are the most important outstanding questions that we should try to tackle next. So now I'm going to switch gears a little bit. I want to talk about 3 specific papers. So the guidelines haven't been released yet. They haven't been published. That should be coming up probably within the next 6 months. But I want to talk about some of the papers and research that will inform some of the guideline recommendations that will be published. This is a very important study from Finland. Some of you may have experience looking at scientific papers, some of you may not, but I'll try to walk you through it here. This study looked at over 300 patients from Finland. All of the patients presented with high-degree heart block. They then looked at patients by how their heart function was. The patients over here on the right had very weak heart muscles with an ejection fraction less than 35%. These patients here had moderate decrease in ejection fraction, 30 to 50%. And these patients over here are the ones that I really want to focus on. These patients have AV block, but normal heart function. And this is very important because many times we make decisions about putting in a defibrillator based on the ejection fraction. And in other diseases of the heart, we often save defibrillators for patients with weak heart muscles. But in sarcoidosis, it's a little bit different, and we often understand that patients can be at risk for fast rhythm problems, even if their heart function is normal or near normal. And so let's take a look at this group here. They called them in the study lone AV block, which means heart block, but normal function of the heart. And so what I want to focus on here is the patients here that are in blue. These are the patients with normal heart function. It's not surprising that the highest risk patients here are shown in red. And over here, we look at risk of sudden death, which is somebody having a cardiac arrest. And over here, sudden cardiac arrest or ventricular tachycardia, a very fast heart rhythm. And I think it's not surprising that the patients with the low heart function did the worst and clearly should get defibrillators. But what's very important in this group is that the patients that had normal heart function still had a significant amount of heart rhythm problems, of fast rhythm problems that would require a defibrillator. And so that's these patients here in the blue and in the green that have levels of fast rhythm problems that's, fairly significant, especially for a group of patients that was fairly young and healthy. So when we look at that amount, if we tally it up over about 5 years, there is a 24% risk of someone with heart block and sarcoidosis, but a normal heart function, of having a dangerous fast heart rhythm problem. That results in sudden death or ventricular tachycardia. And so we think, and we've suspected this before, and this was included in the first guidelines, that most patients with sarcoidosis who need a device, like a pacemaker, usually get a defibrillator. And it's an interesting recommendation that's not common in all of our heart diseases, but this research supports the idea that if a patient with sarcoidosis has heart block, they should likely get a defibrillator even if their heart function is normal or near normal. And that's very important data that we got from this Finnish group. The second study that I want to talk about looks at scar tissue on MRI. And this is a complex slide again, but I'm going to walk you through it. One of the most important things that an MRI can tell us in sarcoidosis is how much scar tissue there is in the heart. And we know that when you have more scar tissue in the heart, it can lead to electrical problems, these fast, dangerous heart rhythms. So if you look up here, hopefully you can see my arrow. This is an example of someone who has normal, this is the left heart chamber, the left ventricle. This is the right side over here. That's a little bit bigger on this one. And so you see this black heart muscle is just schematically showing you that it's normal with no scar tissue and the heart's pumping normal. Over here is the line I really want to focus on. These researchers defined patients that they felt were higher risk. And these patients had a lot of scar tissue. This is shown here with the white. The white area is scar tissue on MRI. So this is a schematic where this patient has some scar tissue here on the left ventricle and some scar tissue here on the right ventricle. And some of the features that they found, this is an MRI picture showing the same thing, that this white area here is late gadolinium enhancement, which shows scar tissue on the MRI. And so these researchers said if you have scar tissue that's just under the surface of the heart, we call that subepicardial, multifocal, meaning in multiple areas, and the septum, the wall between the two chambers, or on the right ventricle, which is over here, that these are all high-risk patients. And when they looked at it, you can see here, so these were the other patients who didn't have a lot of scar tissue or had no scar tissue. The patients that I just showed you a picture of with that scar tissue are shown here. And this cumulative incidence of dangerous heart rhythms or needing a heart transplant were significantly higher if you had scar tissue in multiple areas, scar tissue in the middle, or scar tissue on the right ventricle. And so this is a really critical paper that tells us when it comes to scar tissue on MRI, it's not only important how much scar tissue there is, but location is very, very important. Where is the scar tissue? Is it in multiple areas? Is it on the right side of the heart? Is it in the middle of the heart? And so this paper, I think, is really going to inform some of the recommendations that we have on these new guidelines, telling us that scar tissue or late gadolinium enhancement on MRI, we care about how much there is and location of scar tissue. Okay, and then the last research study that I think was very important that was published in the past 10 years comes from our Cardiac Sarcoidosis Consortium. So this is a group of more than 25 centers that put all of their patients together to learn more about cardiac sarcoidosis. You can see from our map here that a lot of the centers are in the United States, but we're also so grateful to have input from our colleagues in Europe and in Asia. For this study, we wanted to look at how sarcoid patients did with ventricular tachycardia ablation. These are complex procedures, ablation procedures that are done for patients that have very fast heart rhythms. Some of them may receive multiple shocks from their defibrillator. So when you look at this graph over here, overall we had 158 patients, and you can see the number of shocks is shown here before ablation, so the number of shocks from their defibrillators, before ablation and then after ablation. And you can see that overall, the number of shocks came way down when we compare the patients before and after their ventricular tachycardia or VT ablation. So this study very importantly showed that patients with sarcoid and VT can do very well with VT ablation, and that this can really help manage their disease. Now, this is often a multi-pronged approach. These patients may need rhythm medications, they may need other surgical procedures, they may need other treatments for their sarcoidosis. But VT ablation is an important strategy as well in these patients. Okay, so getting back to the document, this document's going to be coming out for public comment in the next several months, and that is for patients, providers, doctors to read over the draft and give some public commentary. Are we missing anything? Is there an area that we didn't address? Is there something that we need to make sure that we consider? So keep your eyes open for that. I can certainly share this with FSR to share the link when this is open for public commentary, and we invite you to share your comments. So again, let's bring this back to our patients. What does this guideline mean to our patients? It means that the research is moving forward. We've learned a lot in the last 10 years, and it's a great time to get together, review our data, and see where we are and how far we've come. Research can be slow, but it takes time to get good data. And I think we've come a long way in the past 10 years. The guidelines will summarize what we know and equally as importantly, what we don't know and what we still need to learn. This can help your medical team make the best decisions for you based on our current data. And it's important that this document is for all care providers, whether or not they're studying sarcoidosis all the time or they see just a few sarcoid patients a year and it's something that they still need to learn about. This document very clearly will give advice of how we should proceed and treat our patients. So coming soon, this document will be released in 2026, later on in the year. It's an international writing committee of multiple specialists and patients that are getting together to summarize where we are at this time. And I think when we take a broader step back, and this really is online with the mission of FSR and perfect timing with Heart Month, the research can take time, but it leads to better outcomes for our patients and their families. And so I think the overall meaning for me is that we do the science and we evaluate the science so that we can bring better options to our patients and their families so they can have longer life and better quality of life. So this can really bring hope to all of us that we're moving forward in the field. So thank you for having me here today. And then I'm going to turn it over to Dr. Culver, and then we'll be happy to take questions at the end.
Thank you, Dr. Kron. That was very interesting. And thank you for agreeing to share the link for public comment. I know our community is going to be very interested in that. And now we'll turn it over to Dr. Culver. Thank you.
Thank you very much for the invitation to speak today. It's always nice to listen to Professor Kron talk. I always learn some things. Thank you all for joining, and happy Heart Month to all of you. I thought that this would be a good time to talk about something that is an important topic for patients, and that's screening. And I saw a question come through just a moment ago about that. I'm going to give you a little bit of an overview about screening for cardiac sarcoidosis. This is a very scary manifestation of sarcoidosis. And I think a take-home message I'd like you to all have today is to talk to your providers, talk to your doctors about it. If you're concerned, if you're having palpitations or passing out, or you're more short of breath, that's good reason to talk to your doctor. Another question that comes up, of course, is, should I do more? How do I look harder for cardiac sarcoidosis? And I want to maybe think a little bit about the perspective on how much should we do to look for cardiac sarcoidosis. And I want to emphasize that the science where we are right now is not quite where we would like to be. And so the bottom line to the end of this story is doing the basics, history and physical and EKG, are the recommended screening tests for cardiac sarcoidosis right now. So here's a quiz. Here are two things. On the left-hand side is a PET scan of a patient with sarcoidosis. It shows areas of inflammation in the body. Everything black is inflamed. And on the right side is a makeup mirror. The question is, how are these two things alike? And this has a lot to do with screening, because as we think about all the tests we have in medicine, similar to thinking about looking in the makeup mirror, we have to think about, are the things we're going to find by our tests going to help us? Are they going to make things better? Are they going to increase longevity, make you function better, make you feel better? Or, like this patient on the left side, be completely asymptomatic, be the cause of a lot of treatment for the patient, and not lead to any better outcomes. And so before we just go running to do every test we can think of, we need to think very carefully about why would we screen a patient? We know we do this for breast cancer. We know we do this for colon cancer and a variety of other things. Why would we screen for cardiac sarcoidosis? And so screening tests, there's a whole science about this. They have some characteristics that they need to meet. And I want to walk you through that to give you a broader perspective on how we think about this in cardiac sarcoidosis. First of all, screening needs to find disease when it's present. So if you have a screening test that's normal or okay, you can be very confident to say, I probably don't have cardiac sarcoidosis. I can go about my life okay, and everything is fine. So it has to be very sensitive. It also has to be simple, easy to perform, inexpensive, and safe. And I'll point out to you that tests that we like to use, and one of the ones we'll pick on today is echocardiogram, which is an ultrasound of the heart, which was a soft recommendation in the 2014 guidelines, cost between $1,500 and $2,500 out of pocket. This is not a small expense in terms of copays, in terms of generalizability around the world, and in terms of what we're asking the medical system to absorb. So it sounds good, but is the cost justified? Screening tests have to be good enough to identify symptoms, disease before symptoms appear. That's obvious. Right? If you have symptoms already, then it's no longer screening. And finally, screening needs to be useful for various populations. It can't just be for people with severe sarcoidosis. It can't just be for people who live in certain regions or of certain races or genders. It needs to be something that fits our entire population. So the general patient population in sarcoidosis needs to benefit from screening, not just ones who are seen in certain centers like just in tertiary centers or just with cardiologists. Screening needs to be a one-size-fits-all proposition. And most importantly, and this is the piece that many people miss on screening, is it has to make a difference in how you feel, function, or survive over the long run. So people a lot of times are saying, let's get a blood test for cancer. Does that really improve your lifespan? Does that really improve how you function over time? So screening needs to result in fewer deaths amongst those identified by screening. So now we're thinking about cardiac sarcoidosis and should we screen and who should we screen? And I think a first concept for me, and this is an evolving concept that we can talk about more, is that not all cardiac sarcoidosis is created equal. Cardiac sarcoidosis that emerges in patients with lung sarcoidosis or skin sarcoidosis who have had it for a number of years tends to be much more benign than patients who are walking down the street with no known history of any sarcoidosis, and they get a problem and it's diagnosed as cardiac sarcoidosis. And here's one plot that depicts that. And in the blue line, you have patients who had known sarcoidosis before, and in the orange line, you have patients who have new presentations. They were fine, and then the next day, they had some problem, and cardiac sarcoidosis was diagnosed. And on the left-hand plot, you can see the proportion of people who didn't have a big problem from their cardiac sarcoidosis. And you can see these two groups behave differently over time. We're looking at 10 or 15 years of time. The people who have a lightning bolt hit them and now they have cardiac sarcoidosis do worse. So if you think about yourself as a sarcoidosis patient who doesn't have known cardiac disease before, you're probably in this blue line and you're probably going to do better. The second thing to think about when we think about screening is that not all cardiac sarcoidosis is created equal. Here's a heart that was taken out of a person who had a heart transplant for cardiac sarcoidosis. And I just listed some ways that sarcoidosis can affect the heart. It can cause fast rhythms, ventricular tachycardia. It can cause blockage of electrical conduction. It can cause weakening or stiffening of the heart. That's cardiomyopathy. And sometimes it can even cause rhythm problems in the top chambers of the heart. I want to remind you that you're also allowed to get these same problems from situations that are not sarcoidosis, even if you have sarcoidosis. So it is really important to see somebody with expertise in sarcoidosis, and specifically in cardiac sarcoidosis, if you're trying to blame your atrial fibrillation on sarcoidosis, for example. I would say most people who have sarcoidosis and atrial fibrillation, I'm going to go out on a limb with Dr. Kron here, it's not from the sarcoidosis. It's because atrial fibrillation is really a common problem. And oh, by the way, you're allowed to get common problems when you have sarcoidosis. The next challenge when we think about this heterogeneity is that we don't have a great way to diagnose it. So anytime we're measuring a screening test, anytime we're looking at, can I find the patients who are really going to have a problem, we have to remember we're not great at diagnosing cardiac sarcoidosis. So again, here's that heart I just showed you. And what we would really like to know to make the diagnosis of cardiac sarcoidosis is we'd like to find these clumps of cells from the immune system, these blue cells that you see over here on the screen. These are all inflammatory cells around this pink heart muscle. And you can see there's a lot of them. Unfortunately, biopsy of the heart is really challenging and it's not very accurate. And you can see looking at the picture on the left why that might be true. The sarcoidosis are all these little white areas in the wall of the heart. You can see the darker brown, that's the normal heart muscle. But if you're biopsying over here on the right side of this, you can see it's quite likely that you would miss that because you're just going in blindly and taking some little tiny hangnail pieces, sized pieces from the heart. So it would be very easy to miss these. So when we think about measuring the effects of a screening test, we have to remember the diagnosis of cardiac sarcoidosis is not a perfect art. And in fact, there are ways to try to get better at diagnosing it. We hope to be better than this excavator over here. There are ways that the electrical doctors like Dr. Kron are using to map electricity in the heart. Some of those might improve our diagnostic yield, but right now we're still mostly relying on imaging tests like MRI and PET scan. So here's a cardiac MRI. I think if you think of one single test for cardiac sarcoidosis that's got the best accuracy, this is the one that I would bank on. But remember, this is expensive and it's cumbersome, and it's not really a screening test. It's a test to make the diagnosis. And Dr. Kron already showed you what the MRI looks like. On the left-hand panel, you can see all the white here. What you should see instead is a black donut. All around this gray should be a black donut, solid black muscle. All this white is areas that are abnormal. Either scar or a lot of inflammation is causing that. And that's very consistent with cardiac sarcoidosis. And if somebody with sarcoidosis had that picture, I'd say they probably have cardiac sarcoidosis. Well, what about the picture on the right? The top arrow here does show some of this bright white. That's consistent with cardiac sarcoidosis, but this bottom arrow might not be if it was in isolation. This might be an artifact. It might be a false reading. And the problem is when we start doing screening, we're subject to a lot of false readings, readings that look abnormal. They get you concerned. They get more testing happening. Sometimes they make treatment happen, but they don't necessarily indicate that you either have granulomas in the heart or that you're going to have something bad happen. And so that raises the possibility of two really important biases that I want to go over with you, because when you just think about it, the earth looks flat, and when you just think about it, everybody should get a cardiac MRI. But the earth is not flat, and I would argue that a cardiac MRI can lead to a lot of overdiagnosis because of these artifacts. Let me show you how that works mathematically. Let's say we're screening 1,000 patients with symptoms in EKG, and that 1,000 patients are found by symptoms in EKG. That's our standard screening technique. And we follow them up for 5 years. And after 5 years, 100 of them die for various reasons. Maybe some of them are sarcoidosis. Then we would say our 5-year survival is 90%, 100 out of 1,000. So 90% of them survived. Now, what happens if we do a screening test that shows a lot of artifact and we start overdiagnosing the disease? Now we have 4,000 patients we've screened. A bunch of them might have artifacts. We would call that pseudo disease, but we still have those same 1,000 patients with actual disease inside our population. If we follow them for 5 years, we'd say, well, now 3,900 patients survived out of 4,000, 97.5% survival. Oh, look how good we were. Did we really improve the survival of these 100 patients? No, we just did a lot more tests and we came up with a number that looks better because we overdiagnosed the disease. Here's another bias I want to point out about screening, and this is called lead time bias. And this means that when you screen, you find disease earlier in the course of the disease, but it does not improve the longevity of the patient. It doesn't improve what happens at the end. So if we think of cardiac sarcoidosis as starting here on the left-hand side of the panel over here, and we're following the patients over time, let's look at the bottom one. They go over time, eventually some symptoms happen, they survive for a while, and then something bad happens, like ventricular tachycardia. Let's say that we find it by screening in this top-hand row. Okay, we found it by screening. Now we follow them. They still survive the same time, but we knew about it longer. So if we don't have effective ways to treat it, it makes it look like things were identified earlier. It makes it look like we had a better survival, but all we did is identify it earlier in the disease course. So these are some of the challenges with screening and why we don't jump into doing every test on every patient, but we think about how are we going to help patients. That brings us back to this 2014 Heart Rhythm Society guideline, where one of the recommendations that a lot of centers adopted was the use of echocardiogram. It said it can be useful in patients with extracardiac sarcoidosis outside of the heart. A lot of patients got subjected to echo because of this. And so we wanted to ask, is that really important? Does that really help our patients feel, function, or survive longer? Now, it's important to remember when you look at any of these guidelines that there are firm guidelines and there are soft guidelines. And the Heart Rhythm Society uses one rubric. Another rubric is called the grade format, and that really gives you strengths of evidence. And it says we would recommend, that means almost everybody should get it, or we would suggest. And it's important to remember that suggest means most patients should get it, but you could have pros and cons, and it would be okay if some people didn't get it. That's a discussion with the patient. Whereas a recommendation is something that should be firmer, and we could use that, for example, as a quality metric. So in that background, we really wanted to ask, do we really need echoes? Does that really help? Is that going to help our patients? And that's the genesis then of this trial, which was sponsored through the Clinical Studies Network at Foundation for Sarcoidosis Research. And that's taking patients with new sarcoidosis and asking, should we do echoes? Should we do prolonged EKG monitoring, Holter monitoring in patients in our general sarcoidosis population? Is that really going to help them? Back in 2014, the evidence basis wasn't as good, but we had studies like this. This is a study from Mount Sinai in New York, and it just looked at all their cardiac sarcoidosis patients, and it said, what was abnormal in the patients who actually were diagnosed with cardiac sarcoidosis? And you can see the percentages graphed over here on the y-axis. And you can see that the Holter, the ambulatory EKG, was the best, but none of these were really that good. And so despite that, echocardiogram still made it into these Heart Rhythm Society guidelines. The American Thoracic Society, on the other hand, has a little bit different guideline. That suggests for cardiac sarcoidosis that we use the standard things, EKG and history. And that means every time you see the doctor, they should be asking you about those questions that might indicate cardiac sarcoidosis. So we designed a study based on this. This is called the PAPLAND study. It's a combination of Papworth Hospital and Cleveland. So this is the land part of the PAPLAND study. This is looking at patients newly coming in with sarcoidosis to the center. They might have had the disease for years, but they were new to the center and they didn't have any symptoms. So this is a true screening trial, and this is the only true screening trial in cardiac sarcoidosis. And we divided them by a coin flip into just symptoms and EKG, the usual pattern, that's the top line over here, or enhanced screening, meaning that they got an echocardiogram, an ultrasound of the heart, and they got either a 48-hour or a 2-week heart monitor, and then that could trigger additional testing. And then we follow these patients up for 2 years to ask, how much extracardiac sarcoidosis did we find with this additional testing? And we originally planned to enroll 600 patients in this, but we stopped a little bit early because of the results that I'll show you. So these are the interim results that I reported at ATS a couple of years ago. And you can see that these patients look a lot like the patients we might expect to see in our sarcoidosis populations. There's more female. In these centers, there were more whites than in general you would expect to see overall in the US, but still a good representation of Black patients. And you can see the smoking and the presence of some other problems that might also cause abnormal MRIs, for example, like high blood pressure and diabetes and coronary artery disease. So what happened when we did this test? Well, very few people actually had abnormalities. And so we ended up with very few extra testing. You can see cardiac MRI was only done in one patient in the standard arm and four in the enhanced arms. Very few people needed a PET scan. And at the end of the day, we only found two patients with cardiac sarcoidosis, one in the enhanced arm and one in the standard screening arm. So what that tells me is that doing these kinds of tests in the general population for all the expense and all the effort and all the burden on patients doesn't really add very much to their care. And we should just go with our standard technique of routine EKG and history, because these tests are not going to improve the outcome for our general patients. Again, if you have symptoms, then you need the tests that we've been talking about today. But if you don't have symptoms, we still don't have good evidence to do these kinds of tests. So I'll just conclude by saying that we're awaiting the final PAPLAND analysis. That testing relies mainly on clinical suspicion and real basic stuff we've been doing for decades. And the fancier tests, although we have them and we can use them to diagnose, they have not yet been proven to improve the outcome. So don't always buy the fanciest, most expensive thing. It's not always better. Right now, blocking and tackling and being simpler is the best way to screen. And I'll stop there, and thank you very much for your attention.
Thank you, Dr. Culver. Excuse me. Thank you both, Dr. Kron. That was so interesting to learn about these new guidelines. And Dr. Culver, thank you so much for covering the PAPLAND study. I wanted our audience to know that that was an FSR funded study and that we coordinated all of the data collection across all of the sites. So very exciting stuff being shared here. And now we have a lot of questions. So I'm going to start. I'll give the first question to you, Dr. Kron. What's your choice of steroid-sparing agents for cardiac sarcoidosis?
That's a great question. So we have a multidisciplinary clinic here, and so I've learned so much from working with our rheumatologists. In our clinic, and it can differ regionally depending on, who's in the clinic and what they're comfortable treating with, we usually start with methotrexate. That's probably our most common steroid-sparing agent. We use other ones as well, including Cellcept and azathioprine. The second line after that, if somebody doesn't tolerate those, we will then usually go to an infusion such as infliximab. I think we generally try to get patients on no or as little steroids as possible, just knowing that there's so many side effects long term. So we do try to get patients onto a steroid-sparing agent and then wean their steroids if possible.
Great, thank you. Okay, Dr. Culver, next one is for you. And there were a number of questions that came in during the registration process about GLP-1s. And what, if any, impact do GLP-1s have on cardiac sarcoidosis?
That is a very challenging question. I am not aware of any studies that look at GLP-1 and cardiac sarcoidosis. Maybe Jordana knows of something. There are some theoretical reasons to think they might help, but I'm not aware of anything specifically in the cardiac sarcoidosis population.
I agree with that. I don't think there's any specific data, but knowing that obesity is such a common problem in our population, especially when patients have been treated over the years with steroids, although it's not super data-based, I do say to my patients that with careful monitoring, if they're interested in trying GLP-1 agonists, that it's something that we think is, reasonable. Now, there may be some anti-inflammatory properties of this drug classification, but I think that data is still, out there and one of the things that needs to be looked at.
Maybe I'll just pick up on that for a second too. We just in WASOG just published a position statement on the use of steroids for chronic management of sarcoidosis. And this is, of course, something that Dr. Kron mentioned, and it's very important to patients. These cause lots of problems over time. They are extremely toxic medications. I would take methotrexate 7 days a week, 8 days a week before I would take steroids chronically. I think it's a much safer drug for most patients, and there are a variety of other ones. So I think that one of the main goals for treating cardiac sarcoidosis, as well as other forms of sarcoidosis, is minimization of steroids. So please talk to your doctor about it. If they're not comfortable finding ways to minimize your steroids, ask for a referral to a different doctor because the toxicities and problems with obesity and coronary disease and diabetes, and you go down the line, are legion, and they're sneaky. They accumulate slowly over time until you have multiple medical conditions, and it's all from steroids.
Thank you. Dr. Kron, what is the benefit of inexpensive heart rate monitors, like fitness trackers, to help with continuous monitoring for asymptomatic heart block? This question, they would appreciate your perspectives on that.
Again, I'm not aware of any data specifically in a sarcoid population. The data that we, in an electrophysiology clinic, we get a lot of data, people wearing their Apple monitors and different kinds of monitors. They send us images of their heart rates. They bring pictures to clinic. These are not medical grade devices, but many times they do provide very high quality data. And so what I would say to our patients is, of course, if you're having a symptom, palpitations, dizziness, passing out, you should see your medical provider and we can do monitors and those kind of things. But that said, these home monitors can certainly pick up irregular heart rhythms, fast heart rhythms, and slow heart rhythms that would be caused by heart block. So, I would encourage them I think if patients enjoy them and get data from them, I think if you have an irregularity on a monitor, you can certainly bring that to your physician and ask them to review it. But there's other patients that too much data gives them anxiety, where they're trying to exercise, but they're so focused on the heart rate that they can't even, complete the workout. So I think some of it is what's best for that individual patient. If it's giving you more data and you feel good about it, that's a good thing. You share it with your physician. If it's increasing your anxiety and you're monitoring all the time, then it's certainly not anything that you have to do. But I think in general, the quality of data that we get from home monitoring is pretty good. And then certainly can lead us to do more invasive testing with medical grade monitors.
Great, thank you. Dr. Culver, so after hearing about the PAPLAND study, there's a question if there's any additional information about other clinical trials or clinical trials in sarcoidosis, cardiac sarcoidosis, or any new treatments on the horizon.
Well, Dr. Kron is running some of the clinical trials in cardiac sarcoidosis, so I should defer to her. The biggest one I think that we're all waiting for is the CHASM trial. David Burney is running that in Ottawa. And that's really asking the question of can you replace prednisone with methotrexate and get similar outcomes in terms of blood flow and other markers of damage to the heart? And again, that is in line with that whole idea that we want to minimize or reduce the use of steroids for management of inflammation and sarcoidosis. So for specific cardiac sarcoidosis trials, that's the one that we're mostly all awaiting. And then there are some smaller ones that are more preliminary. I will say that there are several other medicines that are being used in all the organs in sarcoidosis. There's something called JAK inhibitors, for example, which I think we're starting to find fairly useful for some of our patients. So we'll see more options for patients as we go along here.
Great, thank you. Next question. What does the research show about the long-term prognosis for cardiac sarcoidosis patients living with the disease for 10 plus years? Which one of you wants to take that one?
I'll sort of lay some background work, and then, of course, Dr. Culver, you can jump in. So I will say that I think there's some older data that people would read papers that said if you're diagnosed with cardiac sarcoidosis, you're going to need a heart transplant or you'll be deceased in 5 years. That is very old data. That is before all of our imaging that's picking up patients earlier, our awareness where some patients come in, as we showed earlier, with normal heart function and they're having early arrhythmias and we're picking it up. Because of widespread use of defibrillators, medical therapies, and awareness, we're just doing a much better job. So what I often tell our patients, and I don't have an exact life expectancy that I can give out, but what I tell our patients in clinic is that we're going to manage this like a chronic disease. We're going to get you on medications that are controlling the disease, preventing progression, and we're going to work together to manage this chronically, and keep you feeling well, keep you enjoying this time with your family and your loved ones. And so I think some of that old data that showed poor outcomes was before the imaging we have today, before our understanding of it today, and I don't think a lot of that applies to our current patient population.
Yeah, I agree with that. I think you can expect if you take all cardiac sarcoidosis, the 10-year survival is better than 90% nowadays. And that's because of defibrillators and medications, and we're finding a lot more milder disease earlier and sooner. So I think it's a much better thing than it used to be, and people get very anxious about it. But the other thing is that if your heart function is really pretty well preserved, and you don't have a lot of areas of your heart affected on your imaging studies, then you also are likely to do very well.
Good news. Dr. Culver, can you discuss the impact of stress on cardiac sarcoidosis, or is there an impact of stress?
Oh, this is really a tough one. There are data looking at cortisol levels, looking at stress, looking at brain immune system links on a variety of inflammatory diseases. This has not been specifically done in sarcoidosis, but if you look in the rheumatology literature, there's a lot of data suggesting that it impacts it. So I don't have any sarcoidosis or cardiac sarcoidosis specific data to say if you do yoga and Tai Chi and you get out of your cutthroat job and you find ways to be less stressed, that you're going to do better. But I recommend it all the time. I think it's good general health practice. And a lot of times people use sarcoidosis as an opportunity to reconsider their priorities in life. And sometimes getting rid of some stressful things or managing that differently can be helpful.
Advice. So there's a couple of questions about heart transplant, whether it's the percentage of patients diagnosed with cardiac sarcoidosis who might receive it, and how many or the typical time frame post-diagnosis where someone would need a heart transplant.
So I'm not a heart transplant doctor, but I will say in general, we try to avoid heart transplants, right? We want our patients to keep their hearts and be medically managed as long as we can. That is possible in most of the patients. When patients are diagnosed with a very advanced disease where they already have a very weak heart function, a lot of scar tissue in the heart, those tend to be the patients that really progress more to a heart transplant. I think that's one of the things is sort of how the patients present when they're diagnosed. So we do want patients to be screened early, although that's challenging and has its own, complexities to it. We want patients to be diagnosed. We want to try to treat them. In general, a sort of an oversimplification is that sarcoidosis causes inflammation, and if that goes on too long, it turns into scar tissue. So we really want to try to treat the inflammatory phase. And one of the things that patients ask a lot is, well, what's the difference between a PET scan and an MRI? We both talked about the MRI showing scar tissue. The PET scan is so critical because it shows ongoing inflammation, and that's really at our current stage where we can treat sarcoid to try to get some of that inflammation under control before we get more scar tissue. So I think it's very individualized. I think if you're having a lot of heart failure hospitalizations, a lot of symptoms, first of all, we have wonderful heart failure medications and therapies that can do a beautiful job. And so I would say to ask your doctor to involve a heart failure specialist if that's where your disease is heading, and then get some expert input from someone who is managing heart failure and heart transplants on a regular basis, so they can sort of counsel you about those options.
Thank you. Dr. Culver, is diet important, and the role of an anti-inflammatory diet to either prevent or treat cardiac sarcoidosis?
That's another thing similar to the conversation about stress. I think there are pretty good observational data that say that diet changes the bacteria in our gut. That's the gut microbiome, and it does other things to us that have impacts on inflammation. but there aren't any good randomized trials that say that if you do a diet, it's going to fix your problem. It's kind of like saying if you have a running back on your football team, you're going to win. Well, yeah, every football team has a running back. That doesn't prove the running back is what makes you win. So that's my sports metaphor for the day. But the point is that I think it's good general medical practice to think about those things.
Thank you. So we are at the top of the hour, but I'm going to do one last question, and this is for you, Dr. Kron. Have there been studies done on the effectiveness of the Watchman for cardiac sarcoidosis with AFib?
It's a really important question. So for those of you who don't know, when patients have atrial fibrillation, a very common rhythm problem, we generally put them on blood thinners to prevent stroke. The Watchman is a device that's inserted in the appendage, a little pouch of the heart, to prevent clots from forming. I think the key things to know about Watchman are that it is a similar efficacy to preventing stroke as a blood thinner. It's not superior, it's an alternative. And so for patients that can't tolerate blood thinners or who are having falls or bleeding problems, it can be a really good alternative treatment. I'm not aware of any studies specifically in sarcoidosis patients. I think that decision would need to be made on a one-by-one basis. There's no reason to think a sarcoidosis patient couldn't benefit from a Watchman, but that's something that you should talk to your AFib doctor about, but certainly an option in our patients.
Thank you. Thank you both for an interesting and informative webinar. Thank you for taking all of these questions. It's so great to know that you are both members of the FSR GSCA Clinical Alliance. And I'd also like to thank all of the patients who are attending today who maybe took part in the PAPLAND study, or are helping to further research. And I'd like to also encourage you to take a look at the patient registry. You will be receiving a survey. I hope you complete this survey. We really use all of this information to help us guide educational webinars that we'll be offering in the future. You will also receive a link to the recording of this webinar in that follow-up email. So you can take a look again at the patient registry. But thank you again to Dr. Culver and Dr. Kron. And I hope you all have an amazing rest of your day. Thanks.
Thank you so much.
Thank you.
Happy Heart Month.